conditions that cause physical abnormalities of the chest are called as chest deformities. So what exactly are these conditions and how do we correct them? Let's discuss and know more about chest wall deformities in our today's episode. Hi, I'm Dr. Lakshmi and you're watching Yashoda Hospital's The Health Talk session, where all your health-related queries are answered here. So joining our episode today is Professor Dr. Shyam Kolvekar, Senior Consultant Cardiothoracic Surgeon from London, and Dr. Balasubramoniam, Thoracic Surgeon from Yashoda Hospital, Secunderabad. Welcome to the program, doctors.
Thank you very much.
Thank you. So we'll be having a short discussion with the Dr. Shyam regarding chest wall deformities. Now, I like to ask a few queries to sir regarding how we correct chest wall deformities and what are the common doubts that patients have regarding them. So, sir, you have been operating on chest wall deformities for a number of years now.
Yes, I've been doing it since 2009.
So we in India, we are just about starting to identify and treat people who have chest wall deformities. So what are the kinds of chest wall deformities that you usually see in your practice?
I think pectus means chest. Most of the chest wall deformities, either there is a depression or there is a protuberance, or it could be combination of both. The depression is called funnel chest or called pectus excavatum. There is a variation to it where it's called arcuate. There is another one called pectus carinatum, or as we know popularly as a pigeon chest. Pigeon side where the chest is protruded. And majority of these patients varies. It's more common to have pectus excavatum in this side of the world, and pectus carinatum is quite common in South America. It's a strange fact, but that's what we see most often. It's almost 5 excavatum to 1 carinatum. Because carinatum doesn't have much symptoms and they don't chase up for a treatment.
So we find that the patients are affected by either way they look, because they may have an abnormal chest shape, like you told. Either it be a protuberant chest or it be an inwardly depressed chest. So are there any other heart or lung function abnormalities in these people other than the cosmetic appearance?
Okay, I think initially people thought it's cosmetic because young children have a lot of tolerance and they can survive with all the problems. Excavatum has a lot of problem. If it's a depression is pressing on heart, and then it can cause a leaky heart valve, or it can cause irregular heartbeats. In some cases, heart can stop in between and the child could faint. It also affects your lung function. Some of these patients can be labeled as asthmatic without having asthma, and they treat it with the inhalers, but nothing gets better because chest is pressed so much. They have very small place for lung to expand. With carinatum, there is not much physical problem other than a pain, but you must remember all these conditions can coexist with other connective tissue disorders where they can have Marfan syndrome, Ehlers-Danlos syndrome, and they can have underlying other structure with coexistence.
So we do see parents coming in very over anxious about the cosmetic deformity that their children have. So at what age do we really go in and do something about the deformity? Is there a particular age limit where you do not want to do a procedure or a surgery or something to rectify too early, or is there an age where it's too late? What will be the ideal age?
When we see them, I get people as patient as young as newborn to almost 70-year-old. But initially, when parent comes with their child, you have to see how symptomatic he or she is, and then what you need to do. The majority of children, probably under 10, don't need any surgical correction at that age. But there are lots of options you can do. Exercises, swimming, and occasionally a vacuum bell and carinatum braces There's a lot of, if you surprise that 80% of the pectus deformity doesn't need surgical intervention. They need adjective non-surgical treatment, and that is good enough for make them look better, feel better, and keep them healthy.
So what are the non-surgical options that we have to treat pectus excavatum?
I think non-surgical ways, one of them is exercise, physiotherapy, swimming, stretches. Then for excavatum, vacuum bell is very good tool. It's safe. It doesn't need a prescription, doesn't need much looking after. Child can look after, parent can look after. And there is in a younger age, if you start, there is a 50% success that they may not need any surgical intervention afterwards. For carinatum, best one under 18 is braces. If you put a braces in early age, they never need any surgical intervention. It's so good. There are some braces for excavatum, but very limited effect of it. But these are the non-surgical solution for these children.
So how long do we try the non-surgical options before we say, okay, we have to go in for a surgical procedure?
Okay, for excavatum or a funnel chest, if they have symptoms in spite of the non-surgical treatment like fainting attack, palpitation, exercise intolerance, and you see there's a evidence of heart depression or problem with the lungs, then ideal age to operate on them is probably around age 13 to 16, because that's a good age to operate. It's good for corrections, less painful, and they have full recovery and don't need anything done in the future. But you have to wait for at least a year or two when you do vacuum bell, because every time you put a vacuum bell, it looks good. When you release, it goes back. 50% of patient, it succeeds to look much better and may not under surgical intervention. The braces are amazing. Within 3 months, you get the results, and by 6 to 9 months, everything recovers well. Only in the small group of patients who have a rigid cartilage, then it may not work. If you get a skin ulcers and damage, then probably you need a surgery.
Everybody's scared when you say you undergo a surgical procedure for a cosmetic problem. So is this surgery an open procedure, or is it a keyhole procedure? Is it a major procedure? Is it a minor procedure?
It is always major procedure. Initially there was only one operation called ravage, where we used to excise the cartilage and either lift the sternum or push down and fix it to the rib edges, and that was a standard operation for up to now. Now, Professor Nuss from US designed this operation, which is a keyhole, minimal invasive with a scope to do it, which is well accepted by children and the adult. You can do that from sort of 13 till around age of 30. The cutoff is 40. After that, probably the ravage is a better option. There are other things called pectus up, which you put a plate outside, lift up, but that's good in younger adult and children. And in the small group of people, as you said, it's cosmetic. You can use a 3D anatomic silicone implant to give a fantastic contour to the chest.
So you mentioned about a surgery where the Nuss procedure, where you implant a bar inside. So the bar is actually sitting inside the chest and it's raising your chest deformity up. So when you have a bar inside, are there any precautions you have to take after the surgery is over?
Yes, because there's a bar underneath the sternum and in front of a heart. It's quite a dangerous location to be. So precaution is first 6 weeks, they shouldn't do any exercises. After that, they do cardiovascular, and after 3 months, they can do most of the exercises. There is always a small chance they can displace and bar could move, and then you need to be more careful in that. But you're absolutely right that these patients, you need to watch for first 6 weeks for any displacement in pain. But after that, it settles, becomes a part of their chest.
So the important message is that after a bar implantation, after around 3 months, their quality of life is the same as anybody else. Now, how early do we remove the bar? Is it permanently fixed inside, or do we remove the bar later?
Okay, the external bars are in front of your heart. So they have to be removed. The best ideal age is 3 years, because by then it solidifies and you don't get any regression. Earliest you can remove is 2 years. There is very little chance of regression. And that's why to remove it? Because if you don't remove it, they can migrate. And suppose if you need to give a CPR for any reason, it will be very difficult. And if they need a future surgery on heart or something, the bar will come your way. It's not necessary. It's implant which is just staying there. It's very essential that you take it out after 3 years. I have removed after 8 years. It becomes very difficult after 3 years.
So are there any long-term side effects, like once you have a bar here and there for around 2 years and then we are removing the bar? Beyond that, are there any long-term side effects because of that, because of the surgery we are doing for it?
There are no long-term. If at all, there are all benefits. Only long-term sometimes. You may develop a nickel allergy and they get a redness of a skin around with it because it's been there, and then you need to remove the bar. But if the bar is removed in small percent, if you're early, they can have some regression to the chest. Very rarely when you remove bar, if there is a nerve damage, you can get neuroma and you could have a very painful chest, and they need some bit more pain management to it.
So before we wrap this episode, Dr. Shyam, would you like to share any message with our audience out there?
Of course. I always say, the pectus correction is not life-saving, but it's a life-changing for all young adults. When you see them after do it, I get videos sent by their parents that their child couldn't run and now running for England. Then we see ballerina going ballet, and we had a dance. She's doing a show live somewhere and sending the images. I have changed. I feel I have done something good for this children's life. So as I said, it's not life-saving, but it's life-changing for that person.
Dr. Balasubramoniam, what message you would like to tell our audience out there as far as chest wall deformities are concerned?
We in India have really underdiagnosed and underdiagnosed chest wall deformities. I think it's important to send the message out there that we have treatment modalities and treatment options for children who have pectus, excavatum and cardiothoracic, and they need not hide anywhere because of their cosmetic deformity. They can also get repaired and lead a life as normal as you and me. So I think that's the message that I'd like to share.
And I can say that in Yashoda Hospital, all the things which I mentioned, they will be available here under Dr. Balasubramoniam's leadership. We can do all of these to the patients around us when they come to us.
So thank you, Dr. Shyam and Dr. Balasubramoniam. It was wonderful having you here on our program today.
Thank you very much.
Thank you very much.
So this brings us to the end of this episode. Hope this episode was informative and enlightening, and don't forget to join us for next week as well. Until then, take care and stay healthy. Thank you.